Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Prospective Study of Psychosocial Outcomes of Having Contralateral Prophylactic Mastectomy Among Women with Non-Hereditary Breast Cancer by Parker et al. My name is Sarah Hawley, and I am a professor of medicine at the University of Michigan and research investigator at the Ann Arbor VA in Ann Arbor, Michigan. My oncologic specialty is health services and outcomes research. There is now considerable data documenting the dramatic rise in removal of the healthy breast at the time of the affected breast among newly diagnosed early-stage breast cancer patients, also called contralateral prophylactic mastectomy, or CPM. Because CPM in patients without a familial syndrome or genetic mutation does not confer survival benefit, there has been interest in understanding why patients make this choice, particularly because many are candidates for less extensive surgeries, including breast reconstruction. One factor consistently associated with CPM choice in patients with non-hereditary breast cancer is worry about recurrence. Other factors include desire for peace of mind and for better cosmetic outcomes. Yet there has been little research on the longer-term impact of CPM on those who choose it. The article by Parker and colleagues that accompanies this podcast presents one of the first studies of the association between receipt of CPM and subsequent psychosocial well-being, while also assessing associations between pre-surgery emotional state and receipt of CPM. The study recruited women from surgical appointments at an academic and a community-based cancer center and asked them to complete a baseline questionnaire prior to surgery, including existing measures of cancer distress, cancer worry, body image distress, and quality of life. Participants were then asked these same questions again at 1, 6, 12, and 18 months after surgery. Despite the relatively small sample size of 288 with 50 women receiving CPM, the findings are intriguing. First, the authors found that the proportion of Hispanic women receiving CPM was higher than other racial ethnic groups, with 33% of the 49 Hispanic participants getting the surgery, compared with 13% of white and 14% of African American women, rates closer to recent population-based studies. This finding is in contrast to prior work that has found rates of CPM are highest among white women. The authors note this could be because participants had to be English-speaking. Yet, rates of CPM obtained from SEER registries have been similar between Spanish-speaking and English-speaking Latina women and still considerably lower than white women. Another explanation lies in the role of clinicians and the complexity of patient-surgeon communication. If most Latina women were seen by surgeons or within one practice where CPM was more common, and without a strong recommendation against it, their rates may be higher. Prior work has found that CPM tends to be associated with a patient-driven and high-autonomy decision-making style, which is less common in Latina patients. Thus, patients who defer to a surgeon-directed style, especially when the surgeon does not recommend against CPM, may be more inclined to receive it. Another important consideration is the role of family and friends, shown to influence choices for more extensive treatment in other cancers, and also shown to be influential in the Hispanic population. The high rate of CPM in this population suggests a clear opportunity for qualitative work to better understand this decision. Most notably, the Parker study provides insight into the underlying psychological drivers that may contribute to choices for CPM, as well as the longer-term impact of choosing CPM on key patient-reported outcomes, including quality of life. They found that women who chose CPM had higher cancer worry, distress, and body image concerns before surgery than those who did not choose CPM. This finding is consistent with prior work from cross-sectional studies documenting an association between worry and CPM, yet the Parker study offers some of the first evidence to suggest that the worry precedes this choice and may actually motivate it. Although not measured in the Parker study, it is also possible that those women with greater cancer worry at baseline are more anxious in general. The finding underscores the need for assessment of worry and anxiety prior to surgical decision-making. The authors further found that after surgery, the high cancer worry in CPM patients was reduced over time to the level of women who did not choose CPM, though it was not fully ameliorated. Conversely, work by Rosenberg and colleagues found that after surgery, women who received CPM reported lower worry about recurrence. It should be noted that the general cancer worry measure in the Parker study differs from the worry about recurrence measure. It may be that CPM contributes to helping women worry less about cancer spreading, but not to general worry that may interfere with daily life. This is an important distinction that warrants further investigation. Importantly, Parker and colleagues found that 18 months after surgery, women who chose CPM had higher cancer distress, higher body image concerns, and lower quality of life than women who did not receive CPM. Results from limited prior work on quality of life following CPM have been mixed. Work from the mid-2000s found similar contentment with quality of life in a small study of women with and without CPM several years later. More recent work by Huang and colleagues in over 7,000 women assessed quality of life about 5 years after treatment and found an association between CPM and better psychosocial well-being in multivariable analyses, but the actual differences were small, and receipt of reconstruction had a much greater impact on psychosocial well-being. The importance of reconstruction to patient-reported outcomes, including quality of life, must be considered, particularly since most women with CPM have reconstruction, which can contribute to increased complications and longer recovery time. The timing of the post-surgery assessment in the Parker study, which was much earlier than previous studies, combined with the fact that most received reconstruction, could have contributed to the lower quality of life observed in this sample. Similarly, the finding that women in the Parker study continued to have higher body image concerns after surgery, while the Huang study indicated higher breast satisfaction, could be due to timing and to lack of detail regarding type of reconstruction received. Further, it is possible that overall body image following breast cancer surgery could be low, even in the context of a higher satisfaction with one's actual breast look and feel. The Parker results, combined with research finding lower body image among CPM patients than those getting breast reconstruction, may be useful in guiding decisions in patients who place high value on body image. In summary, although a relatively small study in clinical settings, the results of the Parker study confirm the need for clinicians to address worry both before and after surgery. The study also highlights the need to help women understand the potential downstream impact of the procedure. A recent study by Lee and colleagues found that breast cancer patients underestimated their well-being after mastectomy, but overestimated their well-being after reconstruction, further lending support for helping patients calibrate expectations prior to breast surgeries of all types. Decision tools that address worry and provide women with insight into the experiences of others who have been through treatment may help support patients through the decision-making process and contribute to better long-term psychosocial outcomes. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.